Good morning. Good morning, teachers. So today I'm presenting my thesis data on comparison of safety and efficacy of tailored versus Victor's admin for the management of patient with cirrhosis and sepsis-associated AKI and RCT. Uh, so the main physiological function of the albumin is related to its oncotic property, which can achieve effective plasma volume expansion, and it helps in the mortality rate reduction by 29%, with minimum albumin concentration being advised in the reference studies with the 2.5, and the favorable negative fluid balance being achieved with the albumin, and the need for vasopressor are also sorted without affecting the need for the RAT. Non-oncotic rule of albumin include ligand binding transport as a transport molecule and the antioxidant and the anti-inflammatory properties. So we there is a safe study been done in the patient of AKI where the part where separate section been done for the septic shock patient, where there is a modest benefit with seen in the patient with the refractory shock. This is the AKI management in the patient of the cirrhosis as advised by the ICA, where the stage 1 AKI been treated with the aversion of the nephrotoxic drug and the adequate hydration. And for the stage 2 and the stage 3 AKI, volume expansion and the albumin has been advised. These are the common causes for the AKI in the patient of the cirrhosis, where the PICD and the type 1 HRS and the SBP is the most common. So the key studies in the patient of AKI treated with the in cirrhosis. Among them, the prominent is the short study we done in the 1999, where there is a landmark value of the 1.5 gram of albumin per kg when advised for the patient of the SBP. Another study on the SBP was done with the Salerno, and none of the studies currently been done for the sepsis associated AKI. Among these studies, short study and the Salerno study advised for the AKI in the patient of the SBP, but as sepsis-associated AKI study is not done in much. So sepsis-associated AKI is defined as the occurrence of AKI. Defined as the occurrence of AKI within 7 days of sepsis onset, diagnosed as per the KDIGO guideline and the sepsis criteria, whereas the sepsis-induced AKI exclude injury that primarily develop as the indirect consequence of the sepsis or sepsis therapy. So there is no separate guideline for the hospitalized patient with the sepsis-associated AKI and cirrhosis. There is increased inflammation, creatinine, and the urine output behave unreliably. Sepsis-induced AKI frequently overlap with the HRS AKI, and the profound vasodilation reduces the effective arterial volume. Faster AKI progression, higher dialysis need, and the high mortality makes cirrhosis sepsis destined for the sepsis-associated AKI. This is the pathophysiology of the sepsis-associated AKI, where vasodilation and the prerenal component, along with the inflammatory markers, causes for
Use a pointer. Where are you? Go back on the previous one. You have an important diagram. Explain it.
This diagram shows for the inflammation as an important as inflammation and the release of the PAMP and the DAMP molecule, along with the vasodilation and the prerenal component, which can lead to the sepsis-associated AKI in the cirrhosis patient. Cirrhosis patient with the lower value of the intravascular volume are more predisposed for the sepsis-associated AKI within the 7 days of their infection, and more common in the hospital goals.
Explain the pathophysiologic mechanisms and the progression.
In the sepsis, we have the sepsis and the inflammatory molecules, which causes for the immunomodulation and the inflammation, along with the activation of the complement system, which lead to the release of the endotype, various types of the endotype, which ultimately lead to the structural damage, and also to the vasodilation in the renal disturbance, which further lead to the increase in the GFR with the decrease in the tubular activity. Further, there is a maladaptive function seen in the patient of the sepsis-associated AKI associated with the decrease in the GFR, and further, there is a reduction in the urinary volume and increase in the serum creatinine along with the AKI in these patients. So lacuna in the previous studies include there is no separate guideline for the hospitalized patient with the sepsis-associated AKI. There are no randomized controlled trial that directly compares fixed dose albumin with the focus guided or the tailored dose. There is an unclear balance between the efficacy and the safety, where unrational use of the albumin may lead to the pulmonary edema, respiratory failure, and other cardiorespiratory dysfunctions. So there is a gap in the personalized approach with the role of dynamic, individualized hemodynamic monitoring is the need of the time with optimization needed in the albumin therapy. So my primary objective is to see for the effect of the tailored dose of 25% albumin with the fixed dose protocol as advised in the different studies for the AKI resolution in patient of cirrhosis with sepsis without the development of cardiopulmonary complications. And the secondary objective includes the study of the cumulative dose of albumin at 48 hours and the 7 days, time to initiation of vasoconstriction in both groups, need of non-invasive or invasive mechanical ventilation in this patient, incidence of cardiopulmonary complications, comparison of the effect of circulatory parameters, and the dialysis and the 28-day mortality. So this is a single-centered, open-label, randomized control study at the Department of Hepatology in ILBS, done since started since February 2025. We have included patient of 18 to 70 years age with the cirrhosis and AKI as per the KDO guideline. And sepsis been enrolled as per the sepsis 3 criteria and the survival in sepsis guideline. Excluded, we have excluded the patient who have the AKI other than the renal causes, and patient who are on RT, those who are already receiving the albumin with the shock, with the PF ratio less than 200, with the volume overload, with the baseline IVC more than 20, with collapsibility of less than 50%, pregnant female, lactating female with the SCC beyond million are also excluded. So we have two groups where one received 25% albumin infusion at 20 ml per hour, titrated as per the volume status. The infusion was guided as per the focus to prevent the cardiopulmonary complications. Second group received the standard medical therapy as per the different protocol, where 1 gram of albumin per kg per day was given to the maximum of around 80 grams. For cardiopulmonary complication, new or worsening respiratory distress, hypoxemia, radiographic pulmonary edema, or clinical heart failure occurring within 6 to 12 hours of albumin infusion, where there is a where we need to interrupt the albumin therapy. Taken. The subjective criteria include the tachypnea or the tachycardia in the patient, or the new onset orthopnea or the oxygen desaturation measured with the bedside pulse oximeters. So objectively, we have after having the patient having the symptom, objectively we have defined in those who are having the new onset lung crepitus, in the chest X-ray having the new or the progressive pulmonary congestion, and the focus showing for the new onset B line, with the IBC showing for the more than 20 mm with the less than collapsibility of less than 50%. We have done repeat echocardiography also in this patient, and where there is an increased IBC with reduced respiratory variation and new or worsening MR or enlargement of the cardiac chamber been evaluated. So for stage, we have staged the complication in 3 grades, where the grade 1 were the mild, where respiratory rate has increased more than 18 up to 20, with mild dyspnea, SpO2 dropped from the base level to less than 3%, new onset crackles. In those patients, we have initially slowed down the infusion and reduced the dose of the albumin. In the grade 2 patient who are having the moderate symptoms with the respiratory rate more than 20, up to 22, with dyspnea and the SpO2 decreasing more than 5%, up to 3 to 5% with the oxygen requirement in them. So in those, we have reduced the albumin, temporarily halted the infusion, and treated for the symptoms of the volume overload. In the grade 3, we have stopped the albumin. These patients are having the respiratory rate more than 24. SpO2 has decreased to less than 92 or more than 5%, with the X-ray also showing for the changes of the pulmonary edema, and there is the focus finding of the B lines. So AKI, as per the KDIGO guideline, is defined as the increase in serum creatinine more than 0.3, more than equal to 26.5 micromole per liter within 48 hours, or increase in serum creatinine to more than 1.5 of the baseline value within the 7 days. HRS kidney AKI is acute kidney injury in cirrhosis patient with ascites caused by functional renal vasoconstriction in the absence of any structural kidney disease, not responding to 48 hours of the volume expansion. These are the various stages, where stage 1 has a subdivision in stage 1A and 1B, with the serum creatinine less than 1.5 and the serum creatinine more than 1.5. For monitoring, we have baseline MELD, sodium, and CTP so far been scored. The following parameters were noted hourly, including the heart rate, blood pressure, urinary output, bedside with the catheterization of the patient, respiratory rate, and the Horage index been calculated with PF ratio. Heart rate was measured in the supine position, either manually or using the pulse oximeter, and the patient were given empirical 3rd and 4th generation cephalosporin. Those who are having the sepsis, having the sepsis on the presentation, and then based on the culture report, their antibiotic been changed accordingly. Every 6 hourly, we done the ABG, where we have reported the electrolyte, lactate, and the blood pH. And we had done the daily chest X-ray, renal resistance index for the 48 hours, not in the whole cohort, and serum creatinine were done in patient with the KFT. 2D cardiography was done on the baseline, and those who are having the complication, then the 2D echo was repeated in them. If there is no downstaging of the AKI within the 48 hours, then based on the volume status, GFR, and urine output, diagnosis of the HRS AKI along with the vasoconstriction was added in those patients. To stop albumin, we have followed the grading, and albumin was discontinued, and the protocol-directed management was initiated to them. Those who are having the cardiopulmonary complication with the grade 3 were immediately stopped for the albumin. Their 2D echo was done to rule out any new onset changes. Anti-ProBNP was also repeated compared with the baseline volume, and those with the grade 2 complication has undergone 2D echography also, and there is a reduction of the albumin dosing was done in them. For those who are having the progressive renal dysfunction, were put on the RRT and the vasoconstrictions. Primary outcome is the proportion of the patient having resolution of AKI with cirrhosis and sepsis as 48 hours without the development of cardiopulmonary complication. We have taken the response as per the ICA guideline, where the complete recovery involves the return of the creatinine to up to 0.3 of the baseline, and partial recovery with the down staging of the AKI with or without the achievement of 0.3 mg per dl of the baseline. So secondary objectives, secondary outcomes include the cumulative dose of the albumin in each arm at 48 hours and the 7 days, time to initiate vasoconstriction, and incidence of the cardiopulmonary complications, including 28-day mortality in those patients, and progression of AKI or requirement of RRT. Ethical approval has been done from the Institutional Review Board, and CTI registration has also been done for the study. Sample size is taken as per the American study of the Michael et al., where 72% of the sepsis-associated AKI resolved by the day 5. So assuming the resolution rate of AKI is 70% with the fixed dose of the albumin and with a tailored dose, it is considered to achieve a higher value. We have taken the alpha of 5% and the power of 80%, and we needed to enroll the 96 patients. So assuming for the 5 to 10% of the dropout, we have taken the 100 patients with the 15 with likely 50 in the both group. Randomization done using the IWRS system. Continuous data were represented as the mean plus minus is a standard deviation, and the median and interquartile range were also reported with the categorical data represented as the n with the percentage of their value. Univariate and multivariate logistic regression were applied for predictors of the AKI, and the p-value of less than 0.05 was considered as the statistical significant. So among the results, this is my study cohort where 242 patients were assessed, and out of them, 156 were excluded. Among those who were excluded, 36 were those who were already on the albumin therapy, and 26 were having the AKI, other causes, and volume overload were seen in the 34 patient at the baseline. Those were excluded. We have included the 86 patients. Out of them, 42 were in the tailored dose group, received the tailored dose, and 44 received the fixed dose albumin as per the protocol. These patients were followed for the next 1 month. Among the baseline characteristics, we have the demographic characters where the age, sex were taken. Etiology, we have majority of the patient with the alcohol-related cirrhosis, hepatitis B were 5%, and the metabolic associated liver disease were the second most with the 30% in the tailored group and 25% in the fixed dose albumin. Patients were having the baseline MELD of around 26, 27, showing for the severity of moderate severity of their disease. So far, baseline was around 6 to 8 in those patients, and CTP was around 8 to 12 in those patients in the tailored group, and around the 9 to 12 in the those who in the fixed dose albumin group. Baseline map was around 70. We have excluded the patient with the shock. Heart rate was around 80 with the respiratory rate of around 16 in both group, with the baseline IVC of around 15 in those patients. Those who are having the proven sepsis, 37% are 37 patients in the tailored group were having the proven sepsis, with the sepsis SBP were the most common and seen in the 25 patients in the tailored group, and 23 patients among the 38 of the fixed dose albumin group were having the proven sepsis, having the SBP. Culture positive, we have the patient, we have total of 27 patients who are the culture positive, where E. coli is the most common, been seen in the blood culture of the 6 patients and urine culture of the 8 patients. Klebsiella pneumonia is the second most common, with the seen in the 7 patients in the urine sample of the 7 patients, and only 1 patient having the rhizobacterium in their blood.
What was the indication of albumin in non-SBP? Go back, previous. No, previous. In this, what is the indication?
Indications are for the albumin.
Yeah.
Sir, in the SBP patient also it is advised.
SBP is okay.
All patients had AKI.
Yes, sir. These all patients were having the baseline creatinine of more than 1.5 times of their baseline level. So we have considered them as the.
But they were having high lactate. No, all these patients are quite sick with high lactate.
Sir, initially those patients who presented with the sepsis have the lactate of around 2 to 3 in the emergency, either due to outside dehydration, or most of the patients were not treated adequately for their sepsis.
Go ahead.
Among the inflammatory markers, PCT was around 1.7 to 1.5 in both groups, and with the maximum of around 6 to 7 or up to 13 we have seen in these patients. And urinary parameter, GFR was around 35 to 55 in Taylor group, and around 35 to 50 in the albumin groups. Ascites grade 1 were 7 to 8 in both group, and grade 3 ascites were seen in the most of the patients, with Taylor dose having the 18 and the 19 in the fixed dose. Bilirubin is around 9 to 10 in the tailored, 13 in the fixed dose, and the creatinine is 1.78 plus minus 0.56 in the tailored, and in the fixed group it is around 1.87. With the different stages of AKI, we have the stage 3 AKI patient, 10 patient in each group with the stage 3 AKI, and stage 1 AKI were the most common being seen in the 18 to 19 patient in the tailored and the fixed group. So AKI resolution in the both group at the 48 hours with the in total, we have the 25 patient who had the partial or complete response of the AKI at the 48 hours in the tailored group. That is statistically significant in comparison to fixed dose albumin group. When we have seen those patients within the 48 hours having the symptoms of the cardiorespiratory discomfort, either in form of tachypnea or having the objective finding, among those also, there were the 7 patients, out of which 4 have received the recovery. And among 27 patients with the high dose of the albumin in the first 2 doses have developed the cardiorespiratory failure in the fixed dose albumin. Among those patients, 8 have received the response in the kidney function. So the graph shows for the complete AKI recovery on the day 2 between the tailored dose albumin and the fixed dose albumin, who developed cardiopulmonary complication, where there is a recovery was higher in the tailored dose albumin group, 57% compared with the fixed dose albumin. At day 7, we see much higher response with the 34 patient having the partial or complete response of the AKI in the tailored group, and among 52% patient in the fixed dose albumin. And we see that the tailored albumin achieves significantly better day 7 complete AKI recovery than fixed dosing. This support individualized albumin as the more effective strategy for the early AKI reversal. Among those patients who initially had no cardiopulmonary discomfort at the day 2, among those 17 had among those 17 patients again recovered from their AKI, but with the development of the cardiorespiratory discomfort has developed in some form in them. And this number was among the 6 in the fixed dose albumin group, who doesn't have cardiopulmonary complication throughout their course. So among 23 patients out of the 86 have their having no cardiopulmonary discomfort during their treatment course. Among the cardiopulmonary complications, subjective symptoms of the tachypnea, tachycardia, and the decrease in the PF ratio has been observed. We have seen that there is a statistically significant difference between those who are having the tachypnea at the during their treatment course, with tachycardia being seen in the 24 patients out of 44 in the fixed dose albumin, and among 9 patients only when we have monitored them regularly along with the downgrading of the albumin if needed in those patients. So we have seen that the grade in the tailored albumin dose group, we have 33 patients without any complication, and grade 1 complication has developed in the 5 patients only. But among the fixed dose albumin, grade 3 severity has developed in the 15 patients.
So what is the total albumin given?
With the
You have
tailored,
stopped in 15 patients due to grade 3.
yes, sir.
So what is the amount of albumin given?
Sir, in those patients who are having the grade 3 complication, the dose of albumin in the first 2 days is around 2 to 3 watt, leading to the albumin dosing of around 125 to 150 gram of the albumin in the 2 days of the time of the death period. As per the SWOT protocol, in the SBP patient, 1.5 gram of the albumin was advised, but we have given around 75 gram of the albumin.
7 bottles are given in fixed.
Sir?
7 bottles of albumin.
3 bottles, sir.
3
No,
bottles.
147
Total
grams.
48 hours, sir. 2 days.
In 2 days, 7 bottles of albumin.
Yes, sir, total.
And in the fixed albumin is 5 bottles.
Two to three. Yeah, 2 bottles each day, sir. About 25 grams. So 50 grams, 50 grams, around 100 grams. Sir.
25.
We are giving the 25%.
Okay.
So this is the albumin requirement at the day 2 and the day 7 in both group, and that is also significantly different in both the tailored and the fixed dose group. And patient requiring the vasopressor were in the tailored group. We have the 16 patient out of the 42 who had showed no recovery at the day 2, and they were started on the vasopressor. And among the fixed dose albumin, this number is around 20. Time to vasopressor initiation is also at a later interval in the tailored group compared to the fixed dose albumin. So the proportion of patients requiring vasopressor was similar between the both groups. Although the time to vasopressor use showed a trend toward the earlier initiation in the fixed dose albumin, with overall tailored albumin may delay the need of the vasopressor, but the difference were not statistically significant in both the groups. This is the IVC trend in the both arms, where fixed dose albumin result in the faster and the higher IVC expansion, indicating greater intravascular volume accumulation. Sorry. Greater intravascular volume accumulation, tailored dose albumin show a controlled rise, suggesting more precise fluid management and the reduced risk of volume overdose. Among the CVP, early CVP were not significantly different in both the groups, but after the initial completion of the 25 grams of albumin, from 12 hours onwards, CVP shows a consistently higher rise in the fixed dose albumin group. So this suggests volume overload or a higher feeling pressure with the fixed albumin. Tailored albumin appear to maintain more physiological CVP trend. Urine output and the eGFR also showed the good response by the 48 hours of the volume education with the albumin, where the tailored albumin therapy lead to the earlier improvement in kidney function demonstrated by the higher urine output and the eGFR. We have also done the renal resistive index with the help of the resident in the higher department, where we have done these in the 48 patients, and the tailored group showed a slightly greater decline in the renal resistive index, but none of the difference was statistically significant. We need to enroll more patients for further evaluation of the renal resistive index and the renal head in these patients. So time to oxygen requirement is earlier and higher in the patient of the fixed dose albumin in comparative to the patient who are on the tailored or the personalized regimen. So tailored albumin therapy achieve better renal recovery compared with the fixed dose. Fixed dose albumin causes excessive volume expansion, and cardiopulmonary complication is also more in the fixed dose albumin group, with the urine output and the eGFR improved earlier and more significantly. And this is time. So we have to look for the various protocols to advise for the higher dose of albumin, because the similar result and the better result without cardiopulmonary dysfunction we are achieving in the patient with the lower dose of the albumin. So tailored dose albumin reduces albumin exposure, yet improves early renal recovery and markedly lower cardiopulmonary complication, oxygen need, and the ICU escalation. Fixed dose produces progressive venous and pulmonary congestion without superior renal and survival benefit. And the by day 7 renal function converged. However, the early safety and the physiological advantage strongly favor for the personalized dosing of the albumin.
It's a difficult study. Any comments from the guide?
Very good, Shreyas. I think so. Shreyas took at least 2.5 years to understand what he had to do, but then he was able to do in 2 months' time. All these 86 patients he was able to finish in 2 months' time. I would compliment you for that. And now he has an understanding of what he's doing, and you understand your. So the basic. Would you like to give some messages? What else has to be done, which is still left?
From you.
So the basic thing which we also wanted to do as a part of his study was to understand the mechanisms of albumin and how it causes. So the capillary leak markers and these things are something which we are planning to do, of how it causes the interstitial volume expansion and what it does to the pulmonary vasculature, and whether the baseline status of the patient can predict which patients are going to develop apart from the volume status. So that is the thing. The strategy of albumin is one important parameter, but the kind of AKI, the inflammations cause, these are something which we also need to find out, and the mechanisms. So this is for AKI resolution.
Yes, ma'am.
I think so. You skipped this slide.
Yes.
So would you like to highlight?
We have in this we have seen for the various factors. We have in the univariate analysis we have done for the AKI resolution, and among the multivariate we have seen that those who are having the infection, higher SOFI score or having the high pro-BNP are having the poor renal recovery, and with the tailored dose of albumin we have a very high odd ratio which suggests for that the low dose of albumin can achieve for the AKI resolution in those patients.
Any other comments also?
So I have a comment. Tailoring is the heart of the study, as far as I understand. What all are the parameters, criteria, or the formula employed in the tailoring?
For the tailored dose, we have shown in the study for the intervention in the tailored dose, we have picked up 25% albumin. We have given at the rate of the 25 or 20 ml, and with the baseline inspection also, we have monitored the patient hourly on the basis of their criteria. Bedside monitoring were done, and every 6 hours the bedside focus was done to rule out any non-specific effects on the cardiac function.
Yeah, but you have shown a correlation, a list of parameters and the correlation. If you develop a formula based on those parameters and tailor according to those parameters, it will be perhaps it will be more logical.
We have done it for the AKI resolution, but for the cardiopulmonary we don't get enough of the multivariates. Univariate we have considered in form of anti-pro-BNP, SOFI score, high MELD. So we need more of the biochemical and other parameters to look for cardiopulmonary complication in those patients.
Any other comment?
Shreyas, you have been 25% or 20% albumin? You used 20% or 25%?
25%, sir.
We go back. The slide just go there. But you have given the 60 gram on day one.
Yeah, he's
80
written
grams.
wrongly. Ashok,
70.
rightly you pointed out this is wrong. It is,
70.
I changed it and again it has come. 50 to 75 grams.
Okay. Thank you. Thank you, Shreya.
Thank you, Dr. And today is Madam's happy birthday. Happy birthday.
Happy birthday. Long live Rakhi. Happy birthday.
Good morning, all my respected teachers, seniors, and my dear colleagues. I am presenting my first thesis, efficacy of plasma exchange therapy with standard medical therapy versus standard medical therapy in severe alcoholic hepatitis with high discriminant function, a randomized controlled trial. My guide is Dr. Sastry sir, and co-guides Dr. Professor Sareen sir, Manoj Kumar Sharma sir, Ankur sir, Rajan sir, and Ashish sir. So moving on, this is my timeline for thesis. It was first presented in department in September 2023. It was ethical approval was done in Feb 2024, and CTRI registration was done in March 2025. And first enrollment of patient was done on 8th of April 2024, and last patient was enrolled on 24th of May 2025. So this is the outline of my presentation. First of all, moving on to the pathophysiology of alcoholic hepatitis. in patients of alcoholic hepatitis due to excess alcohol consumption, it lead to, first of all, directly leads to alcoholic steatosis, and it also causes altered gut-liver axis, causing dysbiosis, and it causes intestinal oxidative stress, causing leaky gut or intestinal inflammation that causes release of LPS into portal circulation, causes Kupffer cell activation and release of inflammatory mediators and chemoattractants and cytokines in the blood that causes the further hepatic inflammation with systemic symptoms causing alcoholic hepatitis. So the current standard of care for patients of alcoholic hepatitis, currently we mostly rely on the, first of all, the nutrition. We give the 35 to 45 kilocalorie of calories per kg body weight and protein of around 1.2 to 1.5 gram per kg of body weight. And further, if patient is after ruling out the sepsis and other contraindications of steroid, we rule out, we prescribe around 40 to 60 gram of steroid to patients of alcoholic hepatitis, and we see the response at day 4 or day 7 with Lilly's score. If it is less than 0.45, we continue it with the 28 days and see the response of alcoholic hepatitis. But most of the patients of alcoholic hepatitis, only the 22% are the responders, 6% are the non-responders, and 72% of alcoholic hepatitis patients are the steroid ineligible. So what are the causes of steroid ineligible? Most of it is high DF, MDF of more than 90. Other are the sepsis, GI bleed are there. So what we have to do with these patients? So in view of these, various new therapeutic agents has come into effect that target the oxidative stress, hepatic inflammation, target the hepatic regeneration, gut-liver axis. So various studies which are ongoing and which are already done in the our institute, like the targeting the gut-liver axis, fecal microbiota transplant studies has been done in our institute. For hepatic regeneration, G-CSF therapy has already been done. So our target was this time was to target the hepatic inflammation. That is, this was done with the plasma exchange therapy. So what is done by the therapeutic plasma exchange? It mainly targets the DAMP cytokines which is circulating in the blood. So therapeutic plasma exchange decrease these cytokine and inflammatory markers that decrease the DAMPs, PAMPs, and cytokines and decrease the hepatic inflammation in our body. So in view of this, various studies limited studies has been done in various institutes. First study at CMC Vellore, in which low volume plasma exchange was added with the low dose steroid in patients of alcoholic hepatitis, and it was compared with the standard medical therapy. This study was the basis for the calculation of our sample size for our thesis. In this study, they give low volume plasma exchange with low dose steroid and see the mortality in the patients of alcoholic hepatitis. In this study, 66% patient with plasma exchange group shows survival benefit, and in 16% survival benefit was in the standard medical group. And second study was done, this was the pilot study that was done in PGI Chandigarh. In this, it was a pilot study of 28 patients, in which 14 patient was in the plasma exchange group and 14 patient was the standard medical therapy, in which 30-day mortality was 21% in both groups, and 90-day mortality was 36% in therapeutic plasma group, and 50% mortality was seen at day 90 in the standard medical therapy group. One meta-analysis which was published in 2024 in patients of alcoholic hepatitis, there was no survival benefit was seen in the patients of alcoholic hepatitis with plasma exchange. But in etiology if the etiology was different, like hepatitis B, there was indeed survival benefit was seen in the patients who were done with the plasma exchange. So, small a brief description about the plasma exchange. Here in this study, we have done the standard volume plasma exchange was done, in which around 1.2 1 to 1.2 times plasma volume was replaced. Other types of plasma exchange is low volume and high volume plasma exchange. So in our institute, centrifugation method was used for the therapeutic plasma exchange, which is better than the intermittent flow centrifugation method. So how to calculate the dose of the replacement fluid in therapeutic plasma exchange? Taking around 70 to 80 ml per kg blood volume, if normal blood volume. So plasma volume is calculated by the blood volume into 1 minus hematocrit. Like a patient of 30 years, 50 kg of hemoglobin of 10 and hematocrit of 30, total plasma volume come around 3,360 in the for a standard plasma exchange. And around 200 ml products are available in one packet of our fresh frozen plasma. So around 17 to 18 products we give in patients of normal adult patients for therapeutic plasma exchange. So in our study, these are the lacunae which were there. So there are the limited treatment options other than the steroid in severe alcoholic hepatitis, and it has limited utility and limited data available till now regarding the plasma exchange in treatment for alcoholic hepatitis with high discriminant function. So we hypothesized that the early treatment with the therapeutic plasma exchange in alcoholic hepatitis might improve overall survival in carefully selected patients by removing the cytokines, chemokines, and toxic substances. And our aim of the study was to see the transplant-free survival between plasma exchange therapy and standard medical therapy in severe alcoholic hepatitis. Our primary objective was to determine the transplant-free survival between PLEX with SMT versus STEMT in severe alcoholic hepatitis at day 90. And secondary objective was to see any development of new organ dysfunction and post-plasma exchange complication in severe alcoholic hepatitis, and also to see the change in MEL, CTP, Glasgow alcoholic hepatitis score, ABIC score, IL-6, IL-10, serum biopsy, and TNF-alpha between both groups at different timelines, and average sessions of plasma exchange in the plasma exchange group. This was our inclusion criteria. Patients were taken from 18 to 60 years, severe alcoholic hepatitis with DF more than 80 and less than 120, and patients who have no transplant options in near future for at least 1 month. So in these patients, we have done the plasma exchange. Our exclusion criteria was active sepsis, creatinine more than 1.5, chronic kidney disease, ARDS, pregnancy, HCC, active bleeding. If patient is allergic to replacement fluids, severe hypocalcemia, and failure to give consent. So this was the methodology. Study population was with alcoholic hepatitis with DF of more than 80 and less than 120. Our study duration was 1 year. It was randomized by block randomization in 1:1 ratio with block size of 6 and implemented by IWRS facility. And it was open label study. And after IWRS, it was allocated to SMT and PLEX group. In PLEX, we done 3 to 5 sessions of plasma exchange with standard medical therapy. And PLEX was discontinued if bilirubin is less than 5 and withdrawal of consent if it is intolerant to PLEX, or during PLEX if sepsis occurs, and other complications of alcoholic hepatitis as managed accordingly. Patient was given high calorie, high protein diet, and other supporting medications were given. Sample size was calculated and with suspected to be plasma exchange has better survival of around 16% and 16% in SMT group. So sample size came to be around 56, 28 in each group, and continuing and assuming 10% default rate, we enrolled 30 patients in each group. So coming to the results, around 215 patients were assessed for eligibility, but 155 patients were excluded. And these, the patients who were eligible, they were randomized by IWRS facility, and 30 patients in each group were allocated, and they were followed up and completed the 3 months follow-up. So among the baseline parameters in demographic, hematology, and renal and different scores and inflammatory markers, all parameters were comparable. There was no significant difference was seen. Among the primary objective, we have seen mortality at 90 days in plasma exchange group was around 43%, and SMT group it was seen was around 36%, with no significant difference was seen. So transplant-free survival at 90 days among the plasma.
Go back. What is the number of patients I can't read it? It is
Sir-
the percentage.
Sir, it was plasma exchange group, it is 13, and
How many died?
sir, in plasma exchange group, it died was 13, and in standard medical therapy, it was 11, sir, at day 90, sir.
Go back to previous slide. The gap is so much, 43 and 36. Oh, you made the,
32, sir, is 30, start 32 CPR.
okay.
So transplant-free survival at 90 days, survival probability in SMT group was 63%, and plasma exchange group was, it is 56%, and overall survival was around 60%. In early survival, it was in SMT group, it is 83% probability of survival, and plasma exchange group, it is 80%. So various scores were compared, and their values were also calculated at different timelines. So first of all, among the MELD group, if we MELD score, in SMT group, MELD was decreased from 28 to 24. In plasma exchange group, it is 29 to 21. There was drop in at 3 months. In DF, from 95 to 72 in standard medical therapy group, and plasma exchange group from 104 to 57. In Glasgow alcoholic hepatitis score from in SMT, it dropped from 9 to 8, and in plasma exchange it is 9 from 6.9. That was significant drop was seen in plasma exchange group in Glasgow alcoholic hepatitis score. And in child score in SMT, it was from 11 to 10, and in plasma exchange group from 11 to 9.5, but it was not significant difference was seen, and same trend was also in the ABIC score. And there was also, we have also seen in the change in the inflammatory markers at various timelines, but there was also not significantly difference was seen, and in bile acid, there was also no significant difference was seen.
Why don't you read? Why do you jump so fast? Go back to the bile acid.
In SMT group, bile acid at baseline was 158. So after 3 months, it came around, sir, 88.
After the plasma exchange, what is the bile acid? We're going at 1 month, but after the bile acid, how does it decrease after 1 session, 2 session, 3 session? There's no data on this?
Yes, sir, but yeah.
Okay, so we will come back.
So average number of plasma exchange was done around 3.7 among the total plasma exchange patients. So this was the adverse outcomes and mortality causes. Most of the cause of mortality in plasma exchange group was pneumonia, and 4 patients undergone liver transplant in plasma exchange group.
Mortality is in how many days? Go back. How many days the patients die?
Sir, 1 patient in plasma exchange group.
No, there is a Kaplan-Meier you are showing us. How many days these patients die?
So we have made the Kaplan here. The patients in patients of plasma exchange, group 29 patients were alive at day 20. At day 40, it was 23. Day 60, alive.
1 month, what is your primary objective? 90 days.
Yes, sir.
But where is the 90 days? Because तुमने 20-40 दिया. How many are alive at 90 days?
Sir, alive at 90 days in plasma exchange group was 17, and in SMT group, it was 19, sir.
Okay.
So, among at 90 days, we have what are the various parameters for survivors and non-survivors group. It was not among the groups, it was among the survivors and non-survivors, including the both groups. And it was seen was the MELD score, Glasgow alcoholic hepatitis score, and SDL was the significant predictors for the survival and non-survival patients. And fog regression analysis for 90 days mortality was done, in which in multivariate analysis, SDL, only one predictor was significant, that was the SDL. And we have also made ROC analysis for SDL, in which we have seen the, in which area under curve was 0.758 with
So
P.
what is the HDL? यार तुम पढ़ने ही नहीं देते उसको. पीछे जाओ. What is the HDL level?
So 10.4 was the cutoff.
पढ़ने नहीं दिया. What is the HDL level which decided the death?
So 10.4, sir.
10.4.
Yes. This was the fog regression analysis for 90 days mortality, in which in univariate analysis, Glasgow alcoholic hepatitis score, MELD, SDL, and fibrinogen level was the significant. But in multivariate analysis, baseline SDL was the significant. Only SDL was the significant one. So we done ROC analysis for SDL for 90 days mortality, in which the optimum cutoff value was for SDL for predicting the mortality was 10.4. The patients who were having less than 10.4 SDL has high risk of mortality, and above that, the chances of survival was more, with sensitivity of 91%, specificity of 56%. Positive predictive value was 75 and negative predictive value was 82%. And area under curve was 0.758. So my limitation was, it was a single center study and study was done in high MDF patients. So there was no survival benefit was seen in the plasma exchange group. And we have also not given after post plasma, no added therapy like steroid, GCSA was given. So we can further proceed with that. So plasma exchange may be followed by steroid or GCSF therapy so that survival benefit can be increased. So overall summary of my study, severe alcoholic hepatitis has high mortality. Treatment options are limited, especially in the high MDF patients. In my study, 90-day survival was seen in SMT group, it was 63%, and 28 days survival was 83 in SMT group and 80% in plasma exchange group. MELD, DF, CTP, ABIC, IL-6, TN alpha, and bile acid showed the favorable trends, but there was not significant. Plex was safe and only mild adverse event was seen during the plasma exchange, and SDL was the only independent predictor of 90-day mortality, but no significant survival benefit was seen with the plasma exchange group. So for my thesis presentation, special thanks to Dr. Ankit sir for helping me. And
Comments from the guide?
Sir, This study was done on a very severe group of patients of alcoholic hepatitis, DF more than 80, and even alcoholic hepatitis otherwise also has very minimal treatment options. And we are inclined to start plasma exchange on routinely in wards when we see a patient with a high DF with no transplant option or no other options. This was, and we were already doing it sporadically, and some data came from other centers stating its benefit. Although the data currently on Plex in alcoholic hepatitis is very heterogeneous, some have used low volume, some have used high volume, some have added steroids after the Plex. We wanted to see if it really works and how to go forward with plasma exchange. And Jitendra has genuinely collected the data. There was no issue in him collecting or enrolling the patients. I must compliment him on that. And definitely, we don't see any benefit in this very sick group of patients with single volume plasma exchange. Maybe, as he rightly pointed, we may consider adding sequential to plasma exchange some other therapy, maybe low dose steroids or GCSF or something else after the, or maybe we can consider doing high volume plasma exchange in this group of patients if we are to look at the plasma exchange. But otherwise, this group remains a very rigid group and with minimal treatment options and very sick group of patients.
Any other comments? One of the main things is you have to see at 7 days. We haven't discussed the 7-day mortality and also the how many were ACLF. It's a negative study, so negative studies have to be very careful and you have to reanalyze your data, and especially bile acids and others. So it's a difficult study and a good job. Okay, thank you. And the HDL3 is a very good discovery. There is a recent paper in ASLD also. They said less than 20 is very high mortality. It's a good thing you should publish that.